Hello and welcome back to OBcast. Today we're going to talk a little bit about some of the basics of point-of-care ultrasound in later pregnancy. Now this is something people are generally a little bit more afraid of than early pregnancy, but hopefully we can just talk about some basic concepts that help guide some of your later pregnancy assessment. We're going to focus on a few main areas, and that is just simply fetal heart rate measuring, the presentation of the fetus, i.e. which part of the baby is aligning itself to be the first part delivered, being cephalic or breech. Placental location for evaluating women with antepartum hemorrhage. And just some ways of grossly assessing for gestational age. Now, some people might be saying that this is becoming a little bit outside of their scope of practice or what they feel comfortable with. This is just a reference to show that a few years ago there was some education done in this exact domain for emergency providers, and with very short amount of training they were found to be able to assess all these things just for the basics of late pregnancy assessment with just their underlying point of care ultrasound skills. So this is all something that, if interested, we can use in our day-to-day practice. Now, in terms of how to scan, just some very basic tips that I learnt during my training. And later pregnancy is a different patient body habitus. You need to be a bit mindful of laying these women flat. Some of them get dizzy or uncomfortable. As per early pregnancy, the probe of choice is the curvilinear probe. And there's actually quite a bit of area to cover when you're scanning a late pregnancy or a heavily gravid abdomen. And so I was actually taught to mow the lawn, so to speak, and that is when you're initially scanning the woman, just go back and forth around the whole perimeter of the uterus until you can get a good understanding of the orientation of the baby. And another thing that can help with that is actually to use and orientate a doll on the pregnant woman's abdomen, just to get an idea where you can go back to if you're looking for, say, the legs or the arms or the abdomen or the head, and just to really get a good understanding and grasp of the three-dimensional and moving anatomy that's occurring inside the uterus, which is, I guess, a new thing for most people practicing point-of-care ultrasound. Now, the first thing to mention quickly is the fetal heart rate. This is a skill just completely able to be extrapolated from early pregnancy ultrasound. Now, normal heart rate in late pregnancy is 110 to 160. And then your options for assessing it are to visually count the number of heart contractions over the course of 30 or 60 seconds that you visualize on 2D scanning. You can use M mode, which is again the standard for measurement in first trimester, or you can even try pulse wave Doppler. Now these two options are now pictured here. The only caveat to this is that pulse wave Doppler and any kind of Doppler technology is typically best left till after the end of the first trimester, just in keeping with the ALARA principle, and there's some concerns about the risk of heating a very early fetus. The last thing to say is the clinical standard of care for fetal heart rate measurement is actually a cardiotocograph, which is demonstrated here. But sometimes we don't have these available to us, and an ultrasound can be done and easily interpreted relatively quickly. Now, presentation is important, and I just wanted to mention that in terms of scanning, it can actually be very, very easy to understand whether it's the head or the buttocks presenting for a delivery, if you say you're seeing a woman who's in established labour. And it's worth checking because clinical exam and even vaginal exam on occasion can miss some breech presentations. So this is a picture taken with a curvilinear probe in the vertical axis, and what you can see here is the baby's head coming to where the cervix, which would be in here, the bladder and the collapsed vagina here. So this is a cephalic presentation showing a head being the presenting part. And that's obviously the most common presentation in late pregnancy. This is a transverse orientation of the same fetus, and you can see in this case with the probe in horizontal orientation that we get now a picture that is a little more consistent with where we would measure a biparietal diameter or head circumference. But again, just a way of detecting what the presentation of the fetus is, and it's really quite easy to do. For comparison, here's some pictures of a breech presentation, and what we see here with the probe, in this case both times in the vertical orientation, we see that there isn't a head presenting. And I think that's probably the easiest way to think about it when you're not completely confident what you're seeing. On the left we have a footling breech whereby you can see two lower limbs presenting to the cervix, and on the right it's not clear which category of breech there is, but that's a fetal abdomen. So that's likely to be a frank or complete breech, just depending on the position of the legs, which can't be seen here. So hopefully this demonstrates how easily you can just pop the probe on above the pubic symphysis in either orientation and scan to get an idea of the fetal presentation. Next is placental location. Now, we've talked previously about the presentation of antepartum hemorrhage and really how the primary differential diagnosis is between a placenta previa or a placental abruption. Now, there are some clinical ways of which these can be distinguished, but an important part of any workup for a woman with an antepartum hemorrhage is to work out where the placenta is located. And placenta previa is really defined as a lower placental edge being below the presenting part of the fetus in third trimester. There are, as we've discussed previously, a grading system for this from minor to major or grade 1 to 4, but we don't need to talk about this at the moment. All I really want to get across here is that we're going to look to see if the placenta is covering or down low compared to the cervical os, or if it isn't. Just a side point, when we're thinking about placental abruption, it's important to remember that the ultrasound itself is really insensitive for that diagnosis. So really, for simplistic, in a simplistic sense, this really just is about diagnosing or excluding a placenta previa. Now, in terms of formal sonographic classification, if a placental edge is more than 2 centimeters from the internal os of the cervix, it's considered clear and not a placenta previa. But that's going to be difficult for a novice or someone not used to scanning women to say. So I think the best approach really is just to decide, is this placenta definitely clear from the cervix? And like any bedside ultrasound, if you're not sure, you just call it indeterminate. You can see here that there is a placenta and its edge is going all the way down over the cervical os. So this is very suspicious for placenta previa. In this case, we have a fetal head completely below the placental edge, and this is a placenta that is clear of the cervical os. Just some other examples. We saw this picture initially, but this is what the placenta looks like. It's a large echoic mass, and it can be either on the anterior, posterior, it can be on a lateral wall. And again, we're just measuring to see how far from the internal cervical os its lower edge is, and that's best calculated with the probe in a vertical orientation. Now, placental age is probably pushing the boundaries of what non-obstetric clinicians are going to be using point-of-care ultrasound for, but I thought we'd just touch briefly on some little rules by which you may be able to get some information. And I guess from an emergency practitioner's point of view, it can be useful to determine whether we are dealing with a fetus that's potentially viable. So the first thing I'll say is that point-of-care ultrasound can be helpful in evaluating the fundal height. Now, fundal height in itself has a lot of inherent inaccuracies, but it is thought that a fundal height at or above the umbilicus is possibly associated with a viable fetus. Now, obviously, this depends on whether the baby is lying in a vertical or a transverse fashion, whether there's multiple babies, if there's a significant or a small amount of amniotic fluid, but really it's a helpful starting point, and the ultrasound can actually be used to visualize the top edge of the uterus, and therefore the fundal assessment for someone not so familiar can be made a little bit easier. Now, some simple other rules and measurements that can be useful and again this is probably becoming a bit more advanced, is that the biparietal diameter, and you can see that taken there, of more than 5.5 centimeters is usually associated with a viable fetus, and a femur length over 4 centimeters. And this can be much trickier because multiple limbs can look a bit like a femur, but if that's more than 4 centimeters, you're likely to be dealing with a viable fetus. So that's just one to touch on briefly, but again, probably pushing the boundaries of what most people are going to be comfortable performing. I wanted to talk briefly about formal ultrasound in late pregnancy, really just to touch on some of the ways in which it's used and interpreted. And we're going to talk briefly about cervical length, some fetal growth assessments based on head circumference, biparietal diameter, femur length, and abdominal circumference, because these things really are combined together to give us an estimated fetal weight. We're going to talk about the amniotic fluid index, as well as some Doppler measurements of the uterine, umbilical, middle cerebral arteries and the ductus venosus, and really just try to understand what their role is in pregnancy assessment. And we won't be touching on how we perform these measurements at the bedside, because they are very much becoming more advanced concepts and procedures. So just briefly on cervical length, its main uses really are just in predicting preterm birth in those with threatened preterm labour, and also assessing for cervical incompetence. Some brief notes on this: less than 25 millimetres, the cervix is said to be short, and really the shorter it is, the higher the risk of preterm birth. These women are selected out as they might be at benefit from some interventions. And some interventions that are offered to these women include cervical cerclage, progesterone pessaries, but talking any more than that on those topics is something I don't really want to progress with in this talk. On a transabdominal ultrasound, this is best done with the probe in a vertical alignment, and I'll just make the point that it's probably best done with transvaginal sonography, and I'll show you a picture of that shortly. So here's some pictures of the cervix in long section, and it can be measured as any structure can be measured. It sits just here beneath the bladder, and with a nice full bladder you actually get quite a nice acoustic window here. Some other examples here. This next example highlights how it can be a little bit difficult to clearly see the cervix, and at times a cervical length assessment can be a bit of a guess. And finally, this is a transvaginal ultrasound showing how clear the cervical length can actually be measured in these scans. So really, decisions shouldn't be made regarding short cervixes with transabdominal sonography, but we can certainly get an idea of whether or not a cervix is closed and competent based on simple ultrasound. Now, in terms of fetal growth, we often correlate fetal weight at birth and therefore our estimated fetal weight on ultrasound with outcomes when we're dealing with either preterm birth or a concern over macrosomia. And an estimated fetal weight can actually be calculated in many ways off multiple different measurements, but a very common one's the Hadlock formula, which compromises a calculation between the biparietal diameter, head circumference, abdominal circumference, and femur length. And it's important to realise that with this equation there's an error of about plus or minus 15%. So in a baby that's thought to be 4 kilograms, the error in this case could be as much as 600 grams. So it can be quite significant. It's the other concept that's important to realise, and I'll demonstrate it shortly, is a plotted growth chart, especially with serial measurements done in those babies thought to be at risk of growth restriction, are typically more useful than a one-off measurement when talking about fetal growth and expected weight. So briefly, going through the actual measurements, our first one here is a biparietal diameter taken in cross-section of the fetal skull. On the same image, the head circumference is done. The femur length is shown here, and the abdominal circumference, which probably contributes the most to the error rate due to the compressibility of the abdomen in the uterus, is shown in the bottom corner here. Now this is an older chart showing some of the centiles with estimated fetal weight as per Hadlock's initial article, And I just wanted to demonstrate how using some of these different measurements can actually identify certain fetuses at high or lower risk of growth restriction. So first of all, these blue dots that I'm just placing on the graph, starting at this point here, are going to demonstrate a child that's growing normally. So on serial scans, we notice that this baby starts and continues along the 50th centile. We're going to now use another example. So if this baby, after its 2 initial scans, is sitting on the 50th centile, but then starts to drop to the 10th and then below the 10th centile, this is very much a child that's at higher risk of growth restriction. Now another concept just to highlight, on the top right hand corner is the head circumference. Now this is going to demonstrate a fetus in which the head circumference remains on the 50th centile. But as we look down, the abdominal circumference, while starting on the 50th centile, starts to drop below the lines and actually becomes quite a lot smaller. Now this refers to a concept of asymmetrical growth restriction, in which it's the abdominal circumference that undergoes the biggest reduction. And I guess in a basic sense, the thought here is that there is an inadequate supply and store of glycogen in this child's abdomen and liver specifically, contributing to that reducing abdominal circumference. And this is actually a child much higher risk of intrauterine fetal death or compromise in labour. We'll talk briefly about amniotic fluid index now. It's also used as a marker of fetal well-being. A normal amniotic fluid index on the 4-quadrant method, which we'll talk about in a moment, is between 5 and 25 centimetres. And if you're just looking at the deepest pool of glycol within the uterus, then the normal range is from 2 to 8 centimetres. Now, AFI is used to diagnose and monitor amniotic fluid disorders, and now oligohydramnios is when you have a AFI of less than 5 centimetres or a single deepest pool less than 2, and refers to a inadequate amount of amniotic fluid. The converse is polyhydramnios, and this is diagnosed with an AFI over 25 or a single deepest pool above 8. And really conceptually, when we talk about the 4-quadrant method, what you typically will do here is just divide up the pregnant abdomen and scan for the deepest pool of glycol in each of the 4 quadrants, and then add all those numbers together. And we'll just go through that again in the next slide. So here's a picture of 4 quadrants, and you can imagine them having been taken off the abdomen as divided up on the previous slide. And this just goes to show how they're all added together, and in this case, added together to an amniotic fluid index of 13.5, which is normal. Now the deepest pool in this case is quadrant 4, which has a depth of 4.16 centimetres, and this is what our single deepest pool measurement is. So remembering the normal values for an AFI are 5 to 25, and for a single deepest pool are 2 to 8. These are both women with normal amounts of amniotic fluid. Lastly, I just want to talk conceptually about Doppler studies in formal pregnancy ultrasound. We're going to talk briefly about uterine artery Dopplers. Now really they're just used in earlier pregnancy up until the morphology scan, and they're a marker of upstream placental vascular resistance. If these Dopplers suggest an abnormally high pressure, it can be indicative of a future risk of placental insufficiency, and they're typically monitored in high-risk pregnancies. Now, a very common Doppler measurement done in later pregnancy is the umbilical artery Doppler, and this is really just a marker of downstream placental vascular resistance. And high pressure, which is indicated by either an elevated resistive index or systolic to diastolic ratio, is concerning for the development of placental insufficiency. Middle cerebral artery Dopplers are done. The concept that's important here is that in a setting of placental insufficiency, you can have a redistribution of blood flow preferentially to the brain, as you can, I guess, in any stage of shock in a normal human, or in a fetus. Then you can have a increased flow to the brain, which manifests in this measurement as a low resistance flow in the middle cerebral artery. You can also look at the velocity of flow in this vessel, and that can be a marker of fetal anemia, which is more relevant when we're talking about disorders to do with isoimmunization in pregnancy. The last Doppler that's done semi-frequently is the ductus venosus, and it's more as a marker of fetal heart function. And as the heart function deteriorates due to in utero hypoxia and acidosis, this waveform changes. And in some centres, an abnormal ductus venosus Doppler really is the final straw for delivery in a very preterm fetus. Remember that these early days with the very preterm babies, then every day or week can be precious in terms of its development and outcomes, and that's why it can literally be that these Dopplers are followed every couple of days until an individual threshold is met for the particular fetus. All right, just to go through a couple of examples of the umbilical artery Doppler and how that might change. Just want to demonstrate how the flow in systole, which is the top of this point, versus diastole can change with increasing placental insufficiency. So the next one we can see, if you might notice that the peak is relatively higher than the trough, or the systolic flow is significantly higher compared to the diastolic flow. This made up example at the bottom shows essentially absent end diastolic flow. And this last example shows reversed end diastolic flow. And these four pictures here really represent the spectrum of abnormal umbilical artery Doppler flow. Now, the last thing I'll talk about really is just the concept of how the different fetal parameters change with a compromised baby. And really it's a slippery slope in a progression, as we're about to discuss. And it starts with reduced growth, then a normal umbilical artery Doppler, then a reduced amniotic fluid index, then an abnormal venous Doppler, and the last thing we start to see is an abnormal biophysical profile, fetal heart rate trace, i.e. the cardiotocograph, and then a loss of fetal movements. And these final things really are pre-terminal. On the biophysical profile, very briefly, this is a different investigation to the usual fetal well-being scans, and this is actually an acute assessment of fetal well-being done by observing the fetus's breathing, body movements, and fetal tone. Not all centres use this investigation, but I just want to touch on it briefly so it's understood. But the other components, which make a total of 5 components for a biophysical profile, include a cardiotocograph and an amniotic fluid index. Now, the last thing to mention is that the concept here is that a lack of fetal activity is suggestive of fetal compromise. But it's important to remember that you need to scan these women for at least half an hour, just because fetal sleep can manifest as a reduction in breathing, tone, and body movements, and that can very quickly give you an abnormal biophysical profile. So excluding normal sleep, which should have a cycle duration no longer than 30 to 40 minutes, is just important when you have a baby that is not seen to be moving. And this final table really is just a summary of what aspects of those 5 characteristics make a biophysical profile normal or abnormal. Now, that's all I really wanted to say about point of care ultrasound in late pregnancy, and then in addition to that, some of the aspects around formal sonography in late pregnancy. I hope that's been somewhat helpful, and I look forward to seeing you next time.